Hi, everyone. My name is Mark Stebbin. I'm past president of IUSTI Canada and actually president of the International Society for STD Research. So before we go to our speaker tonight, I'll talk a little bit about the membership drive that we have. So just to remind you that the membership includes networking opportunities, specialized content via the webinars, volunteer opportunities, scholarship opportunities for early career researcher, and also to be associate member of the American STD Association. So the cost per calendar year is $60 for regular membership and $30 for training. Next slide. So during the meeting this summer, from the 26th of July to the 30th of July, we will have the STI and HIV 2025 World Congress here in Montreal at the Convention Center. And there's a special event happening before the Congress. It's the ASTDA IUSTI Canada Early Career Development Session. So this is about career development for early career professional, but it's mainly for North America. And there's still room. There's some room that has been taken. So if you're interested, you can go on the website and the next one, please. And at the meeting, we'll have IUSTI Canada Annual General Meeting. Yeah, so it's going to be Monday, July 28th, 11:30 to 12:30. So it's going to be difficult for us, and we will not have virtual access to the meeting. So for those that are present, be there. Next slide, please. And now it's my pleasure to introduce a good friend, Professor Catriona Bradshaw. She's professor and head of research, translation, and mentorship, and she works at the Genital, Microbiota, and Mycoplasma group at Melbourne Sexual Health Center, School of Translational Medicine, Monash University, Alfred Hospital. So it's my pleasure to now let the microphone to Catriona. Please, Catriona.
Thanks, Mark, and thanks so much for the opportunity to talk today. So I'll just share my slides. Okay, now I'm just checking, Mark, that you can see everything. Is that right? It's on a good screen view? Yeah, from the sound
It's
of things.
okay.
Perfect. Okay. So thanks for the invitation to talk today. Obviously, I'm going to be talking on involving partners in the treatment and prevention of BV, which is an exciting new regimen or approach that we can use to improve cure for women with BV. Isn't that fantastic when slides don't advance? There we go. So firstly, I'd like to acknowledge the Bunurong and Wurundjeri clans of the Kulin Nation, who are the custodians of the land and waters where I live and work, and to pay our respects to elders past, present, and emerging in both of our nations. So BV affects 1 in 4 reproductive age women globally. And we see a marked alteration in the vaginal microbiome that's characterized by a reduction in optimal lactobacillus species and an increase in bacterial diversity and facultative and strict anaerobes. And we loosely refer to these days as BV bacteria or BV-associated bacteria or even BV-related bacteria. And accompanying this, we see really profound changes in pro-inflammatory cytokines, chemokines, the proteome and the metabolome. This all results in an increase in vaginal pH and a malodorous vaginal discharge and the presence of clue cells, which you can see nicely here in this sort of middle panel. So these clue cells are exfoliated vaginal epithelial cells coated in BV bacteria, probably representing biofilm. These profound changes and disruption increase a woman's risk of acquiring STIs, of acquiring and transmitting HIV, and of a range of obstetric and gynecological sequelae, so PID, preterm birth, spontaneous abort, low birth weight, and cause really significant distress and impacts on quality of life and relationships. Now, as everyone's well aware, our globally recommended treatment for decades has been solely directed to women. And that is with a week of oral metronidazole or intravaginal clindamycin cream, 5 nights of intravaginal metrogel. And they all have really similar efficacy at 1 month, so 70 to 80%. But if you follow women, more than 50% of all women experience BV recurrence within 3 to 6 months of our recommended strategies. But if you look at women with an ongoing partner, recurrence rates are as high as 60 to 80%. And we haven't made any significant improvement in BV cure for decades. And this is largely because the pathogenesis of recurrence has been quite poorly understood. So we've had a couple of hypotheses, perhaps persistence of BV bacteria in a biofilm, reinoculation with BV bacteria from sex partners or even endogenous reservoirs. Other factors may play a role, so failure to recolonize the vagina with desirable lactobacilli following antibiotics, host immunological or behavioral factors, and there's less evidence to support a significant role for AMR. And it's been unclear if one dominant pathway drives recurrence or if there are differing mechanisms between women or whether it's actually multifactorial. To compound the problem, the etiology has been unclear, so we really don't have this neat scenario where we have a single infectious agent that's exclusively detected in women with BV and absent in women without. So we know BV is a profound polymicrobial dysbiosis, but it's still unknown if BV is caused by a single pathogen from the onset. So perhaps a pathogenic strain of GVAG with cytotoxic and adherent and biofilm forming capacity, or a polymicrobial consortium of organisms from the outset that then displace the optimal lactobacilli. If lactobacillus depletion occurs first, enabling overgrowth of BV bacteria. Most clinicians will be pretty aware of this in clinical practice. They see women coming in to see them with acute onset, first episode, BV, profound discharge, odor, they know something's wrong and they've just hooked up with someone in the last week. And the incubation period really does appear to be 3 to 4 days, consistent with that of other bacterial STIs. Christina Musney really nicely showed this in a study of women having sex with women, where they did daily sampling using sequencing and showed this really interesting increase in the relative abundance of all of the key BV bacteria in a stepwise fashion within 4 days of incident BV, which was Nugent BV in this case. Now, I've shown this slide actually for a few years now, but published data really consistently show that incident and recurrent BV are strongly associated with behaviours that support sexual transmission. So we see BV associated with increased numbers of sex partners, associated with early age of sexual debut. It's uncommon in women who have never been sexually active with others. We see incident BV associated with new male partners and female partners, penile vaginal sex, inconsistent condom use. And then we see very high concordance of BV, 80% in couples with vaginas, and concordance of specific BV bacteria. We see incident BV associated with a range of practices in lesbian couples. And conversely, recurrent BV, we see that associated consistently in longitudinal studies with ongoing exposure to a regular partner and inconsistent condom use. So this epidemiological data consistently shows that BV has the profile of an STI. Acquisition being associated with new partners, change in partner, lack of condom use, and recurrence being associated with ongoing exposure to a regular partner. Just what you would see with chlamydia or gonorrhea if you're not treating a regular partner. This really started to suggest to us 20 years ago that reinfection was playing a significant role. We have strong evidence for male carriage of BV bacteria and male involvement in the pathogenesis of incident and recurrence. So we see the subprepucial space in the urethra harbouring these BV bacteria. They're more commonly detected in these anatomical sites in the male partners of women with BV than without. And we see concordance for these bacteria amongst heterosexual couples. The composition of the subprepucial space in urethra is also influenced by male circumcision and penile vaginal sex. And interestingly, male circumcision reduces detection of these bacteria in men and the risk of incident BV in female partners. We see a biofilm dominated by these bacteria in the urine and semen, more often in male partners of women with BV than without. And Supriya Mehta did this lovely study a few years ago now showing that the penile microbiota was actually predictive of incident BV in female partners. So data really consistently support a largely asymptomatic male reservoir of BV bacteria in the urethra and penile cutaneous sites, exchange of BV bacteria between sex partners with a penis and vagina, and a role for males and the penis in the acquisition and recurrence of BV. So despite really compelling evidence that female or vaginal-only treatments haven't achieved sustained cure, and compelling evidence for these reservoirs of BV bacteria in men and male involvement in the acquisition and recurrence of BV, why have no guidelines recommended male partner treatment? There have been a lot of trials, which was quite off-putting to consider doing another one. So 7 failed to reduce recurrence. Now, 6 of the early trials did have quite significant methodological limitations, and these were really nicely summarised in a systematic review by Supriya Mehta, who pointed out that due to quite significant limitations, their findings were inconclusive, and it wasn't evidence that BV wasn't sexually transmitted, just that the trial findings were inconclusive. But another major factor is all of these trials only used oral therapy in men. And we hypothesized that failure to use an intervention that targets both the urethral and penile cutaneous sites may have contributed to lack of an effect. Now, this was informed for me right back in 2009 by a slightly overlooked secondary analysis of an RCT of male circumcision for HIV in Uganda. So people who are old enough will remember the 3 amazing trials in Rakhine and Rwanda and South Africa that all produced these stunningly similar efficacy estimates for HIV of about 60% protection with male circumcision. So the Rakhine group did a secondary analysis and actually showed that the female partners of males randomized to male circumcision experienced a lot less incident BV. And these data were really informative for me, and it started me thinking about the penis and the foreskin and the role it plays. So we decided to evaluate 7 days of oral metronidazole combined with topical clindamycin in males to try and eradicate BV bacteria from the urethral and cutaneous microbiota of male partners. So we undertook 2 pilots initially to assess the impact of concurrent male partner treatment on the genital microbiome of couples and to get a sense of the BV recurrence rates, and importantly to generate data on tolerability and adherence. And I'd like to do a shout out here for Lenka, the epidemiologist who's been working with me for over a decade now, and Erica Plummer, who is our bioinformatician. And both women have been amazing partners in this journey. So women in these pilots have a really high burden of risk factors for recurrence. They're highly motivated and desperate, which in lots of ways is good, but in many ways is bad because you feel like you're set up to fail. So obviously the 50 women all had to have a regular partner to come in. Interestingly, 80% of their male partners were uncircumcised, which we know is a risk factor. 80% of women had highly recurrent BV, and we know that is a risk factor. And a staggering 30% had IUDs. And we know copper IUDs particularly are associated with increased risk of acquisition and recurrence of BV. So we were expecting recurrence rates over 3 to 4 months of 60 to 80% in our pilots and in our trial. Our 1 month recurrence rate in the 50 couples with concurrent combination therapy was 8%. Now, interestingly, that compares to the recurrence rates in our cohorts of women who either are not having sex or who don't have a regular partner. So that was quite encouraging. Our 3 month recurrence rates in the smaller group who went through to 3 months was 17%. So again, we look like we've made some inroads here. We used targeted 16S gene sequencing to test for differences in the composition of the microbiota following treatment in the men and the women. We saw a really significant decrease in the abundance of BB bacteria in the vaginal microbiota immediately post-treatment at day 8, so from blue down to pink for BB bacteria. And this was sustained right through to week 12. So again, really encouraging. We saw a significant decrease in the abundance of BB bacteria at both male anatomical sites immediately post-treatment. So a rapid drop down at the penile cutaneous site and a rapid drop at the urethral site. So again, evidence of immediate effect. And this was sustained through to week 12, although it wasn't quite as strong an effect as we saw in women. So these data collectively gave us the confidence to proceed with writing a grant, applying for funding, and doing the dreaded the 8th randomized controlled trial. So we called it Step Up, really in the hope that we would get men to step up, because this is a big ask for couples. Men don't have symptoms. You're randomizing individuals. There's a lot of discussion about we don't know if this intervention works or not. So, and we know this dogged the previous trials. Recruitment and adherence was a really big issue. So the primary objective was to determine whether concurrent oral and topical antibiotic treatment of male partners receiving, of women receiving first-line therapy for BB significantly reduced the risk of recurrence compared to female treatment only in the 12 weeks after randomization. Our primary outcome was 3 to 4 AMSELS criteria. So we needed women to come back in and they needed to have a Nugent score that lay within 4 to 10 within 12 weeks. We had a number of secondary Nugent outcomes, microbiota outcomes, and adherence and AE outcomes. So we started this trial just before COVID. We did the trial through COVID. Melbourne was an extremely heavily locked down city. And Australian cities were generally fairly locked down, and we were all very isolated for quite a period of time in Australia and quite late getting vaccines. So it was challenging. It was always going to be challenging, but it was even more challenging. This was a multicentre randomised open label phase 3 trial conducted largely in sexual health services and some family planning services across 3 states. Women needed to be 18 years of age or older, and they were screened and eligible if they had symptomatic BV, met the diagnostic criteria, the AMSEL and Nugent criteria, had a regular partner for the 8 weeks prior to enrolment, no other partners at enrolment, were not known to be living with HIV, and not being treated for PID. They could then refer their male partner, and the couple were eligible if the male was also 18 years of age or older. They needed to enroll within a week of their partner, confirm they had no other partner, and no contraindications to the antibiotics. Now, one of the other problems is we really needed couples to commit to closed relationships for 3 months. And that's actually quite a challenging environment in STI services. Obviously, having concurrent partnerships, disclosed or undisclosed, results in reintroduction of BV bacteria and undermines the intervention. So we spent a little bit of time explaining the reason that we had this requirement to couples and asking them to keep their relationships closed. If they didn't, to please disclose this in their questionnaires, and their questionnaires were confidential and not shared. So all female participants received first-line antimicrobial treatment. So this was predominantly oral metronidazole, with a small proportion having clindamycin if it was contraindicated or they didn't really want it. The couple were randomized 1-to-1 to intervention or control group, stratified by IUD use and male circumcision status. Now, our control group was global standard of care, female treatment. The intervention was concurrent combination antimicrobial therapy for males. So males had the week of oral metronidazole and 2% topical clindamycin applied from the tip of the penis down to halfway down the upper shaft, twice daily for 7 days. We told couples if they were randomized to the control group that they would have access to partner treatment if recurrence occurred. And our study endpoint was BV or no BV within 12 weeks. We did AMSEL scoring at baseline week 4, week 12. Nugent scoring was more frequent, baseline day 8, week 4, week 8, and week 12. We recorded adverse effects and adherence at day 8, And the microscopists who assessed Nugent score on clue cells and amine result were blinded to group. So we were powered to detect a 40% decrease in recurrence, and we aimed to recruit 342 couples across all sites, so a big sample size. The interim analysis, though, was planned after 150 randomized couples by an independent data safety monitoring board with an extremely conservative stopping rule that could be applied if one arm was statistically inferior. Our primary analysis was a modified intention to treat analysis, and our evaluable population needed to have at least one treatment dose and be assessed by AMSL and Nugent criteria. And Lenka did all the analyses in Stata according to a pre-specified statistical analysis plan. So we looked at cumulative recurrence rates per year, time to recurrence by arm, Cox regression analyses to generate hazard ratios. We stratified our data by IUD use and circumcision status. So we assessed 357 couples for eligibility for randomization. 164 underwent randomization. Now, 193 were ineligible or declined, and we had quite a lot of women declining because they didn't feel comfortable discussing BV with their partners, men declining because they didn't want to participate, and some individuals who didn't meet inclusion criteria. The trial was stopped prematurely at interim analysis by the Data Safety Monitoring Board, which was why we only ended up with 164 couples. 83 were assigned to female treatment only, global standard of care, 81 to partner treatment. We lost another 12 to 15. We had some screening failures in sites that didn't have a lab because they sent their slides to us, and a little bit of loss to follow-up and withdrawal. So we ended up with 68, 69 in the modified intention to treat analyses in each group. Now, the majority of couples were recruited at sexual health services. 1/3 of couples did self-refer from the community. Like the pilots, most couples had multiple risk factors for BV recurrence. Obviously, they all needed to have a regular partner, which we know more than doubles the risk of recurrence. 1/3 had an IUD in situ, which was just like the pilots. That compares to 8% in our population in Australia, so we can see how amplified this is as a risk factor. 80% of men were uncircumcised again, but this time nearly 90% of women had a history of highly recurrent BV. Importantly, all risk factors were evenly distributed between the arms, but this is a group of women with an extremely high burden of risk factors for recurrence. So our primary outcome was BV recurrence, which was 3 to 4 AMSL's criteria and a Nugent score of 4 to 10 within 12 weeks. So the Kaplan-Meier survival curve really nicely demonstrates the highly significant effect of the intervention. So in the solid line, we see the intervention group, dotted line, we see the control group, and we see really rapid separation of the groups. We had a recurrence rate, or we had recurrence in 63% of the controls and 35% of those undergoing partner treatment, which gave us a hazard ratio of 0.38. You can see the confidence intervals well away from 1 and a highly significant p-value. The per protocol analysis, which required individuals to be more than 70% adherence, showed a slightly stronger effect, but very similar. So we saw a reduced risk of recurrence in the partner treatment group versus controls in all stratified groups. So this little graph here shows the hazard ratio. This is the modified intention to treat down here at about 0.37. What we can see here are the hazard ratios for recurrence for women with and without IUDs. We can see that they're all very similar, and partner treatment reduced recurrence in IUD users, which is a really important clinical message. It's worth trying, even with an IUD in. We did have fewer women with copper IUDs, so you can see how this well and truly crosses 1 to confirm. Partner treatment reduced risk of recurrence in couples where the male was uncircumcised. So this is another important message. This is a very big risk factor as well. And we can see here really similar hazard ratios. Now, women were great in the pilots and in the trial in adhering to therapy. They consistently had higher than 90% adherence to all doses, all 14 doses of metronidazole or clindamycin cream. Now, in the pilots, men were pretty good to metronidazole, and adherence to 100% of clindamycin cream was sitting in the mid-70s. But what we can see here is that they were reasonably, or quite adherent to their metronidazole, but topical clindamycin cream really was a problem. Only 50% applied all doses. So it dropped down even in the trial to lower levels than we saw in the pilot. And this is really important because recurrence rates are influenced by adherence. So if we look at this little graph here and we see BV recurrence rates per year, we can see the recurrence rate in control groups is more than 4, sorry, I'm in clinic at the moment, is more than 4 in the control group. And we can see the recurrence rate in the partner treatment group sitting down at about 1.6. Now, if we look at these recurrence rates that are stratified by adherence in men, we can see that these open symbols here represent recurrence rates in women whose male partners were less adherent. So we can see that they're all a bit higher than the recurrence rates in women whose male partners were more adherent. So the take-home message really was that the recurrence rate was 1.3 for women when their male partner was 100% adherent. So adherence matters. The medication was tolerated very well by men. They had actually the expected metronidazole side effects, but at a lower rate than women. Very well tolerated. The clindamycin cream was very well tolerated with a little bit of penile redness or irritation in only 4. Similar in the pilots, no one needed to stop their cream. So concurrent male partner treatment with oral and topical antibiotics greatly improved BV cure, and this was sustained over 3 months. It was well tolerated, reasonably well adhered to, with strong effect in a population at really high risk of recurrence, and female partners of men who adhered to treatment had the highest rates of cure. Partner treatment was effective among women with an IUD and women with uncircumcised partners. So partner treatment using a short, affordable, available, and well-tolerated medical regimen really substantially improved BV cure for women over 3 months. Why did the intervention work? Well, I think we believe that the addition of topical antimicrobials to target and eradicate penile skin carriage was really important. But we also went to a lot of efforts to address the potential limitations of past studies. So there was a really strong emphasis by recruiting staff on the need for closed relationships for the trial, on high adherence, and importantly, abstinence during the 7 days of treatment. So the trials really provided the first conclusive evidence to show reinfection from sexual partners is a significant driver of recurrence, and the evidence needed to confirm that BV is sexually transmissible. And it's obviously a fairly significant shift in knowledge and in clinical practice. And it's a major advance in our understanding of the pathogenesis of recurrence and treatment failure. And this is really important because it's now helping us investigate this remaining smaller pool of women where partner treatments failed. Now, for some, we can see we clearly haven't prevented reinfection. The men didn't take their medication. Some of the women didn't. They had sex during treatment. They had concurrent partnerships. Perhaps some men need slightly longer duration of therapy. But for others, other women, they're really likely to be experiencing BV persistence. And we're seeing this in some women who just still have BV at day 8 and they haven't resumed sex. So we're calling this group the persister group. And they may have perhaps dense biofilm. IUDs are overrepresented in this group. So I think this is really made big inroads into helping us understand and develop more individualized, multifaceted and or extended treatment strategies to really address persistence to achieve our goal of high rates of cure for all women. We've learned a lot of lessons. One is it's really important to support women to discuss BV with their partners. They're often really reluctant to do this, and it's a hard discussion, and you can help them by providing some language, engaging men using inclusive, non-stigmatizing language. We talk about exchanging and sharing good and bad bacteria and interactions with people and partners, involving partners to improve cure, shared responsibility. All of this language helps get everyone on board. Explaining an intervention only works if all individuals in a partnership receive treatment, if everyone takes all of their medication, and we avoid sex during treatment. We've designed quite a lot of partner treatment resources. So we've co-designed resources for clinicians, consumers, and for pharmacists, and they're available on our webpage here. If you just type BV in focus or bacterial vaginosis in focus, they'll come up. And I encourage people to look at this site and use the information and adapt it for your services and your patients. There's a really nice little article here, and it includes some of the amazing couples that participated in the trial and their personal experiences. This is a couple of snapshots of the pages that talk about, you can click on these tiles: partner treatment for couples where one partner has a penis, partner treatment for couples where both have a vagina, how to have the conversation with your partner, raising partner treatment with your GP. We've got really simple cartoons on partner treatment that people can adapt for their services, a neat little animation, again, that's quite accessible. Obviously, one of the really big issues here is we've got clindamycin packaged in countries as a vaginal application with vaginal applicators and vagina all over the box, and it's off-putting for men, it's off-putting for pharmacists. So we've created a pharmacy letter that you can send with your prescriptions with patients to the pharmacist, so they don't say, what on earth, I'm not dispensing this. Simple instructions for a label that just helps generalizability and uptake. So we've done some qualitative studies in participants to understand their experience. This paper's been published. There's a QR code here, and I'll just go through a few of the quotes in a minute. I think we're okay for time, Mark, aren't we? Have I got another 5 minutes?
Yes, yes.
Yep, all
Problem,
good.
Catriona.
Perfect. We're doing a cost effectiveness study at the moment, an open label extension study, which we've actually just stopped. And we're really focused now on factors causing treatment failure in couples to develop further treatment strategies to improve cure. We've got a clinician survey going on in Australia to look at the barriers and enablers to implementation of male partner treatment for BV as well. So I've just got a small number of slides on our qualitative study because I think it's really interesting. BV is not something that's had a lot of qual work done on it. We've done a couple in the past. So we did some semi-structured interviews with step-up trial participants to understand their experiences of BV, male partner treatment, their healthcare needs. They actually provided review and input into some of the patient information on the website, and it helped generate themes and sub-themes. Relationship factors really played a big part, but also ease of access for treatment for men. So one of the themes was experiencing BV. So participants really reported physical, emotional, and relationship impacts of BV, which worsened with repeated episodes. So the physical symptoms of BV in women prompted feelings of embarrassment and reduced their desire to engage in sex. And I think Taylor exemplified this by, her comments. It affected her relationship. Her boyfriend was good about it, but, it was in her head. She had to feel good about herself, and it made him feel like she wasn't attracted to him. And comments like, why are you never in the mood? Why do you turn me down? Literally the tears that have been shed over this. And this has come through in all of our interviews where women are avoiding sex, and it is having an impact on their relationship and making often their partner think that it's a male partner factor. So another theme was dealing with BV alone, and this was a very dominant theme: the frustration, the cost, the inconvenience. So women who undertook individual treatment for BV bore the burden of recurrence. And sorry, I'll go back. I'm trying to get rid of the picture of me, which keeps covering my text. As well as physical impacts associated with repeat infection and antibiotic use. Participants reported time and financial costs of having to repeatedly attend healthcare providers. So Anna commented that she got BV once or twice, treated by her GP, kept repeating, it was unsatisfactory. and she just felt they were doing the same thing, which is what our guidelines have recommended. She wasn't feeling great about this and felt that nothing was changing. Nicole said everything she tried until the step-up trial, every single treatment, it initially worked, but it always came back. Speaking again to reinfection. Getting everyone on board was important. So understanding BV and partner treatment was central to both men and women undertaking it. So both women and men reported poor knowledge before their own or their partner's diagnosis, which often resulted in delays in seeking treatment. So Lachlan commented, and we saw this from a few men, that the last word vaginosis fully implies that it can only infect women or those with vaginas. So of course, 99% of men are thinking it can't infect me. I'm not affected. I don't have symptoms. I can't get it. I can't spread it. Beth commented that it took a bit of a leap to get the courage up to talk about it, but it made the communication a lot more open. And lastly, dealing with BV together was a theme. A week of inconvenience and sharing the responsibility came out in our videos as well as these qualitative interviews. So couples really described it as a week of inconvenience, a short-term sacrifice to help the female partner achieve symptom resolution and improve their relationship. So medications, avoiding alcohol, sex, and potential side effects were really viewed as minor compared with the inconvenience of repeated BV infections. Daria commented that reminding each other to take the medication was actually good, even a bonding experience. And Rohan said taking the antibiotic 2 times a day, it wasn't super complicated, a bit bothersome, but having it come again and again was a bit bothersome. So if you have to wait for a week to have unprotected sex, it wasn't something massive to worry about. So obviously this is a bias of men who actually participated, but I think this helps. We've published this, and as I said, we've got testimonials. It helps men really understand that it's not the biggest deal. So male partner treatment for BV really opens up exciting new opportunities for BV cure and prevention. Reinfection is a dominant but not a sole driver of treatment failure. So we do need to pursue additional strategies to achieve and support a vaginal microbiota that's associated with optimal sexual and reproductive health for all. And we need an evidence base for partner treatment to improve cure in the LGBT community. So we're actually currently doing this in Australia at the moment. So my last slide, I'd just like to thank everybody involved in the study, particularly my team here, this bigger picture, my Lenka, my epidemiologist, and Erica, my bioinformatician, and all the nurses and RAs, our participants and collaborators, and funding from the National Health and Medical Research Council. And we have time for questions, and I'm just going to stop sharing. Thank you.
Thank you, Catriona. Very interesting, especially since it can also drive physicians and nurses crazy when they have those patients coming back. So we think about the patient, but let's think sometimes about the doctors and the nurse.
Yeah. I was going to say, and that we know that leads to us avoiding tackling the problem.
Mm-hmm.
So clinicians don't like not having a solution. And so they tend to try and get patients out of their office, and that just feeds into this cycle of frustration and people seeking, unusual, ineffective self-help remedies.
In the question, we have a question about why not oral metronidazole alone? Why combination?
Yeah, so there was a beautiful trial done by Christina Musney, Jack Sobel, and Jane Schwepke of oral metronidazole alone. Didn't work. It probably didn't work because of adherence issues. So there was a secondary analysis done. So I would recommend you read that trial. That trial was beautifully done and addressed a lot of the limitations of the other studies, and it was well powered. They had very high recurrence rates, 80% in their control group and their intervention group. A sub-analysis of recurrence in women whose male partners were highly adherent showed some effect, but it clearly isn't enough to eradicate that cutaneous carriage. The bugs are just sitting there. They're not invasive. So we don't have sort of metronidazole oozing out of our skin. So I think you need a topical agent.
And why did you go with clindamycin cream instead of
Yeah.
metronidazole gel?
I played around with the gel. I decided it wasn't so adherent, and the cream was really good. Like you could rub the cream in. So we all had gel on our hands and clindamycin on our hands. And so one was the formulation, and the other was the spectrum is quite good for clindamycin. So there is a paper actually from Rupert Call's group that looks at the effect of some of these antibiotics on BV bacteria. So again, I would recommend you look at that. And I think at the moment we're really pretty happy with the clindamycin, but that's not saying that we shouldn't or others shouldn't look at metronidazole gel, but it's worth looking at that formulation first and seeing how suitable you think it is for penile application.
Thank you. Is there any consideration for trial-only topical treatment for male partners?
Well, when you look at the sequencing data and the microbiota data, so when we sequenced our samples, we're sequencing the trial samples at the moment, so we only have our pilot data, but we actually found most of the GVAG inside the urethra. So the actual profile of the BV bacteria differ a little bit across the two anatomical sites. So it is important to eradicate urethral carriage. So therefore topical is really not obviously going to do that. So this is again why we've gone for combination therapy.
Thank you. Someone was asking about the slides and the recording. So we have the recording of Catriona's presentation, and there will be availability of the slides on IUSTI Canada website in few days or a few weeks. How do you approach patient with symptoms and are signs suggestive of BV, but they're not positive on testing?
Well, I guess it depends on what diagnostic test you're using. We're very privileged at Melbourne Sexual Health Centre. I've been working in this space for 20 years. So 20 years ago, I set up both Nugent and AMSLs as routine care. So every doctor gets it within 10 minutes of examining a patient. So that is not representative of clinical practice globally at all. What we did in this trial was I recommended that clinicians in the community, in the absence of a microscope, actually always measure vaginal pH. So record the discharge, do an examination, record the discharge, the odor, the pH, and if you have 3 out of 3 AMSL's criteria at the bedside, they've got BV. Now, obviously, it can be a bit tricky in populations where there's a high prevalence of trichomonas. You know, some places are using NAT tests. So depending on the performance of the NAT tests that you're using, that is a better substitute than using nothing as well. So what I do, what you may be referring to is that group of women who have an intermediate microbiota. So that 4 to 6 group. So I recognized this a long time ago and looked at hundreds of our cases. And you at Melbourne Sexual Health Centre, where the prevalence of BV is reasonably high, 50% of women who have intermediate flora have BV by AMSL's criteria. So they're just intermediate because they've got a few lactose there. They haven't lost them all yet, generally, is what it is. So I'm very comfortable treating a woman with a Nugent score of 4 to 6, and perhaps she doesn't quite have all 3 or 4 AMSL's criteria because she's cleaned the discharge out, or she doesn't have an odor. I would be uncomfortable if she had an acidic vaginal pH. I would not think that reflected BV at all. But you know, I think if you're an experienced clinician and they don't quite fulfill the criteria, but you're fairly confident that she's got signs of a non-optimal microbiota, then it's fine to go ahead.
Yeah, I think there's a problem with the way it's dealt in Canada because usually we say 4 to 6, it's not BV, it's indeterminate flora. But I tell frequently the students like it's a mini BV, it's a BV
Yeah.
in the making.
It is
So
a BV in
I
the
think
making, and some women just like sit like that. I agree, and that's where bringing in the Ansell's criteria is really useful because that resolves it for at least half of those women.
yeah, any relationship between undiagnosed Mycoplasma genitalium or Uroplasma erythlicum and recurrent BV?
So Mycoplasma hominis, yes. So Mycoplasma hominis is very much associated with Nugent BV and Ansell's BV. We've actually looked at that. The ureaplasmas, no, they don't have an association. Mycoplasma genitalium, which is what the question was about, is very highly concurrent with BV. We're seeing this in a study we're doing on PID at the moment. We've seen it in another study on cervicitis. So we do see really quite high concurrence of those two infections. But I think, at suboptimal, non-optimal microbiome increases your risk of every STI, including HIV. So I think it's more perhaps a feature of that. Um,
Someone is asking, are you offering partner treatment via partner delivered partner therapy, expedited partner, or having the male partner come in and having the clinician give the treatment?
yeah, it's a really good question. So this is now all about the logistics, which are really dependent on people's practices. So in Australia, expedited treatment, partner treatment is only legally allowed for azithromycin, and that is for chlamydia. So it's not given for anything else. And so it's not done for this, not officially anyway. The way we did this trial was telehealth. So we didn't insist on seeing the men. Some came in, some were there at the time of the diagnosis of BV, but we did telehealth. It lends itself really well to telehealth if you have that facility. My personal view is if you're dispensing a week of oral metronidazole and clindamycin, that you should actually have some sort of discussion with the patient that you're dispensing to, so that you're not open to medico-legal issues and so that they've got a good understanding. You want them to actually take the medication. So what we say to couples, which includes men who are randomly walking in now to our service, is that first of all, we need to know your partner has BV. We need to know that she has had first line treatment for BV and that you haven't had unprotected sex yet, and that we're really trying to synchronize the treatment. So it's all about, trying to treat both individuals at the same time, trying to make sure people aren't having unprotected sex until both people have finished treatment and discussing concurrent partnerships. So this is, an STI. We're all used to dealing with partners with STIs, but it is combination therapy and it is a week of treatment. Men can't come in and have a test to confirm that they've got BV like they can chlamydia. So it does require a clinical consultation, but I definitely don't think it has to be in person. And you can use e-scripts to send through to patients, but I think there should be at least a phone call and a discussion and an opportunity to ask questions.
Yeah, there's a comment about changing the messaging to indicate that it's an STI will further drive the ongoing stigma around female genitals as dirty and will create a demand by heterosexual male for primary PV treatment. So
Yeah, I
certainly
think
it was a concern. I like the letter you prepared for the pharmacists because I feel that all the pharmacists will be phoning in for that Dallas and cream for the penis.
Yeah. Look, the stigma question is a really interesting one. My response to that is I think it's by far a greater disservice to actually tell women it's just an imbalance of their bacteria. This is what women are being told. It is just an imbalance, but we don't really know what causes it. And it sends women off down rabbit holes looking for self-treatments, self-cures. They get really frustrated. They use non-evidence-based treatment. So actually, it stigmatizes it, saying it is just a woman's problem, which is the whole issue around BV and its name. So what we're saying is we're now bringing men into the equation. So in fact, it's less stigmatizing and more inclusive to say that men are part of, or penises are part of the problem and the solution. So I think it is the language, but I think that it is actually, it is far better to have this evidence, and is far less stigmatizing, for women, for them to understand what's going on.
Someone is asking why copper ID would be increasing the risk.
Like it says two factors for IUDs. One is any foreign body in a human is a nidus through infection, and they get coated in biofilm. So we know pessaries do as well, and rings. So a foreign body attracts bacteria, and obviously once they build a biofilm, then antibodies can't penetrate, host responses can't get there either. So it's associated with persistence. But coppers particularly are also associated with more bleeding, and some of these BV bacteria, such as GVAG, are heme requiring. So they rather like blood, which is why you hear women say, oh, my period has caused it. Their period hasn't caused BV. It's just caused an increased growth of BV bacteria at that time, the heme requiring ones, so that the threshold is changed. They notice the symptoms, the odor, etc. So we absolutely have conclusive published data from other groups about copper IUDs. They're not great at all for BV. We're looking at hormonal IUDs that look like there's a signal again, a non-favorable signal for BV acquisition and recurrence, but we're going to be doing a bigger study on that. And so the jury's out for those at the moment. And I think one of the things that's important to say is that contraception is given to women with never discussing the impact of contraceptive agents on their vaginal microbiota. So in fact, hormonal contraceptive, the oral contraceptive pill has quite a favorable effect on the microbiota, so much so that we even evaluated it once as a sort of treatment for BV. So it really promoted a lactobacillus dominant microbiota. IUDs, particularly copper IUDs, have a non-optimal effect on the microbiota. And so we do need to understand more about the impact of these so that is part of the discussion between clinicians and patients. Because at the moment, contraceptives are just about preventing pregnancy and not about optimal long-term sexual and reproductive health.
Someone is asking, how come you got the media interested in your research?
I didn't. I didn't get the media interested. They just left on it. Do you know what? I have done so many media interviews, and every single journalist has been female. Incredible. All the health journalists. It's consumer driven. Women are really interested in this. And so it has been just taken up in an unprecedented way. I didn't expect this at all. Um, and and on the whole, I haven't really had much non-favorable feedback. So the stigma thing has come up, and it's a very legitimate thing to raise, but it is I think it is important discussion. But yes, I think the media love things like the new STI, but BV is common. It affects 1 in 4 women globally. In some populations, it's 50%. So to actually have the first ever strategy that improves their likelihood of cure is actually a big deal, but I'm equally surprised that the media got so interested.
We have maybe to discuss now is probiotics in, out, on the fence. What's your pick on
Yeah.
probiotics?
Well, I guess all probiotics aren't equal. That's the first. And, there have been really nice systematic reviews on probiotics that show that most of the trials have limitations, just like the previous partner treatment trials, apart from the large oral metronidazole one, that have really rendered their findings inconclusive. So we've got at least a couple of published reviews showing that. Most of the probiotics didn't contain vaginal species. And then that takes us to Craig Cohen's Lactin V trial that actually has Lactobacillus crispatus. That was published in the New England Journal of Medicine, that showed following oral metronidazole that it was about a 30% reduction in recurrence in all women. These were women not with a regular partner specifically. That looked really promising. And I think that coupled with, the vaginal microbiota transplant work, all are sort of proof of concept that some women will benefit from having a Lactobacillus crispatus type probiotic to support their microbiota, not as a sole therapy really, but as an adjunctive therapy in all likelihood. So I think that work is important and it needs to continue. My understanding Lactin V is still not commercially available. And so in the absence of that, we are not recommending probiotics because there is no evidence out of any of the commercial formulations that things work. And I think the extension of that is it's really important to know what's in your formulation. So people are using lactic acid, and a collaborator of ours has studied all the lactic acid formulations, and most of them are cytotoxic and hyperosmolar and damage the epithelium. So again, these studies are not done for these over-the-counter products. And some of them, and we learnt that, remember Mark from Nanoxyl 9, nasty, pro-inflammatory ingredients. So I think, I say to women, don't put things in your vagina unless it's been subject to really rigorous, evaluation and it's actually prescribed, because I'm really not a big fan of over-the-counter stuff.
In Canada, we were using a lot boric acid and vitamin C. Any thoughts about is there still place for these
Yeah, I
acidifying
wasn't aware
agents?
of the vitamin C, but I've
Yeah.
been aware of a lot of trials of vitamin C for all sorts of things, high dose intravenous for viruses. And my understanding is that rather like vitamin D, that it's had a fairly sort of insignificant effect on things, but I really can't comment for sure on BB and vitamin C. Boric acid, I've talked a lot to Jack Sobel about boric acid because obviously he's the guru that invented it. And he is of the belief that it has a very modest effect. So again, more adjunctive. We use it in women with highly recurrent BB and thrush, or in women who don't want more antibiotics. I think what we now have ahead of us is a really exciting opportunity to deal with reinfection, because all of Jack's studies showed that it worked while you were taking it, but when you stopped it, women reverted to the recurrence rate of the placebo group. So, but their partners weren't being treated. So I think then we're very interested in the next studies where you actually deal with the partner and then look at strategies that include boric acid to deal with the index. So I think there is more exciting work, but it is our only biofilm disrupting agent that we can access. It isn't that available. We have to get it compounded. Everyone gets it compounded, and then there are issues around, is it dosing inside, what's in it, what is in the product that you're actually accessing.
So that's all the time we had. I have to thank you very much. How you can take a subject that was not necessarily be very sexy and to entice the interest of people at night. Very nice work, Catriona. Congratulations to you and your team. And by the way, we had a meeting this week about the International Union Against STI. And we know there's a webinar coming on contraception and microbiome in women. So I
Yay.
don't know exactly the date, but stay tuned. So
I will.
finishing,
so much.
I will show the ad for the STI and HIV 2025 World Congress. There's still room for the early carrier pre-Congress day of training. So I hope to see you in Montreal. And closing, I would like to thank Anna for all the work she done on the logistic, and also Greg Penny with all the virtual transmission of this meeting. So thank you very much, Dr. Bradshaw. Very nice seeing you and hearing about your research. Thank you all. Good night.